should be on already.
Good afternoon, everybody. Hands up for who can hear me. Any hand, anywhere? There's one. Thank you very much, Kim. So welcome everybody to the Suitcase Club of the, what's the date? The 7th of November. Thank you very much to Dr. Sam for setting it all up. And thank you very much to Dr. Kim for agreeing to do this. Our title today is, let's see if we can move this on. Yeah. Okay, it's a Mac, so we've got to do it in a specific way. A bite-sized crisis, the arbovirus on your stoop. And we're going to ask Dr. Kim, can we go ahead? We've got all the people on the DCV on. We've got a couple of people that have used their old link. So Dr. Sam is just organizing a new link for them. So I'm going to introduce Dr. Pieton, completed her MBCHP in 2004 at Wits University, but she's well known to all of us. She's been in private practice in Rosebank since July 2018, and she holds an honorary post as consultant of infectious diseases at Chris Hani Baragwana Hospital, and a dual position with the University of the Witwatersrand as a lecturer. On this end, most of you know all of us by now in the Rosebank Fire Station Travel Doctor Clinic. And the reason for the Suitcase Club is really just to remind people that we are part of GeoSentinel. Lucille Bloomberg, who's in Addis Ababa today, is my co-director for GeoSentinel. And the purpose of GeoSentinel is to report on ill-returned travelers back to GeoSentinel. That is a joint venture between the International Society of Travel Medicine and the CDC in Atlanta. We use travelers as sentinels of things that are happening. And in that respect, I think we presented last month 2 cases of trypanosomiasis that emanated out of Zambia, Zimbabwe. And there were a couple of other cases as well. So we're asking you to please, if you're aware in your practice of any interesting, in fact, infectious disease that has come in across the border, whether it's malaria, trypanosomiasis, or something exotic like the cases Kim is going to present today, please let us know about it. We'll fill in a form on your behalf if we have to, just so that we can present the cases. So that's GeoSentinel. That's where you can present your cases to. Just a reminder that we've got Shingrix, which is the killed zoster vaccine, available on Section 21. And maybe I should just mention here, and there it comes up. Thank you very much, Dr. Sam. Malaria prophylaxis. We're still stuck with Section 21, atovaquone proguanil for children. Hetero is supposed to launch the product on the shelves by middle next month, provided they can convince SAPRO to do the necessary paperwork. And we're also providing mefloquine for pregnant women who have to travel to malaria endemic areas. First prize is they don't go, but if they have to go, then they should be on mefloquine unless they've got contraindications to that. And then I want to thank Sanofi, because at the end of the presentation we forget to thank. But thank you very much to Sanofi, who's provided very nice eats and drinks to all of us that are present in body and not just in spirit. And too bad for the rest of you. You should go and get a beer from the fridge. And then I'm going to hand over to Dr. Pieton. Thank you very much.
Thanks, LB. Hello, everybody. Can I have a glass of wine if you're all going to be on beer?
Right, I'll get it up there now.
Can I start sharing my slides?
Yes, you can.
I'm just trying to work out. Okay. Who's over there with you all?
Usual suspects: John Freen, Mary Ross, Therese, myself, Sam, Dr. Cecile,
One new face. Dr. Weiss.
Sister Linda, Sister Renette, and Dr. Robert.
Okay, cool.
You had a whole tour.
Yeah, thank you. It's nice. I'm sorry I'm not there with you all. I see my slides aren't up on the thing.
Thank you.
Okay, so we're chatting about dengue. It's not an unknown case. It's it's a giveaway today. So, I mean, dengue is such an odd fever, such an odd name. It used to be called dandy fever in Barbados, and they say because of the stiffened forms and dread of motion in patients. So we're not 100% sure where this word initially came from. It might have been from a Swahili phrase, kadinga pepo, which apparently means like a cramp-like seizure caused by an evil spirit. So I think just showing how people didn't understand what dengue was. And then the Queen of Spain, Louisa, apparently had dengue fever. And so they used a Spanish word to describe it. And from kind of dandy fever, it's turned into dengue fever. And I think the point is it just seems to mean or imply the terrible pain that people get from this and really can't move. And all the patients which I've seen definitely describe this terrible, terrible pain. So travel doc referred a patient to me 2 or 3 weeks ago. She's 36 years old. She was initially born and raised in the Central African Republic, where she lived in the capital city in Bangkok. Her parents owned a house. I think she said they have some water drilling operation. Parents have moved out, but they've kept this family home in the capital of the CAR. So it's like any other house, full amenities and a family cat that still lives there. And so she goes back regularly to visit the friends that are left and stay in the home. She herself works for African Parks as a compliance manager, and she needs to travel on a regular basis through the 22 African parks to do audits for the compliance. So she's not exactly a ranger, but she says she does need to go into the bush, into the parks itself to go and see that what needs to be done has been done. It's not purely an office computer-based job. She's got no chronic diseases. She's had no previous surgery. She's not on any medication. She's not allergic to anything. She drinks occasionally. She doesn't smoke. She's never been pregnant. She's not on contraception. She's a monogamous with her husband, and her periods are normal. So in July and August this year, she was in Sweden visiting her parents, staying in their home and doing typical holiday stuff. One of the things which she likes doing is going on hikes. And during a hike, she got a tick bite and got a typical bullseye rash, which she describes and was diagnosed as having acute borreliosis. She was treated with 3 weeks of penicillin, which is interesting, came home to South Africa, still had a very sort of what sounds like cellulitic looking bite mark from where the tick bite was. And the GP in South Africa, when she got back in September, gave her 2 weeks of doxycycline. And since then, everything's healed. She feels 100% better. Then she had to go to the Central African Republic. So she was there from the 1st to the 24th of October. As I said, stayed in the family home with her husband, who, by the way, is also an African Parks employee. And she started feeling sick on the 15th of October. I'm sorry, I hope this writing is visible to you guys. It's quite minute on my screen, so I'm sure it's quite small for you guys. But basically, she had a flu-like illness with a fever, myalgia, malaise, severe body pains, and conjunctivitis or red eyes. And she says she woke up with a fever and such bad pain that she was just lying on the floor and couldn't move. She didn't have a rash. She had a couple of vomits, but no diarrhea. She's had multiple previous episodes of malaria, so she thought this must be malaria and immediately started a course of Coartem. But after completing the Coartem, she really felt no difference. The fever was still ongoing. The pain was still terrible, and so she went to the local clinic. She hasn't had any recent travel vaccines, but she thinks they're all up to date, and she thinks she's had everything that's necessary. She can remember having had a yellow fever vaccine, her hepatitis vaccines, and a typhoid vaccine, but none of this was recent. So she goes to the local clinic where they test her for malaria, which is negative, and the doctor starts her on ciprofloxacin, 500 milligrams twice a day for 3 days. She doesn't feel any improvement in the body pain, but over the next sort of 48, 72 hours, the fever slowly starts settling. And then I'm not really sure why they changed antibiotics, but around day 6 or so, she's still really feeling rotten, although not as pyrexial. They changed her to cafixime 250 milligrams twice a day. She describes having a normal period on the 11th of October, which stopped as what was expected. And then a week or two later, she starts having a really heavy PV bleeding and also had 2 episodes of epistaxis. So not feeling any better, feeling that she's not improving on medication and not knowing what's going on, a decision is made that she needs to leave the CIR and come down to Joburg. So she flies out, and in the morning she lands at 4:30 in the morning and comes to see me in the RIMS, which is day 8 of her illness. Oh, I knew there was something I'd left out and I couldn't find it when I was going through it just now to see what it was. But I see now. So her vital signs were actually all normal. She had a normal blood pressure. Her heart rate was normal. Her temperature was normal. Her respiratory rate was normal. Her sugar was normal. She had no lymphadenopathy. She didn't have any rash. She had no arthritis and no bites. She had bilateral red eyes, which she said had improved compared to previously. Her cardiovascular, respiratory, and abdominal examination were all completely normal, as were her neurological exam. And although she describes this, now improved back pain and sort of bone pain, it's not really joint pain. She didn't have arthritis. She didn't have any obvious arthralgia or lumps and bumps anywhere. So these are her results from the Central African Republic for 3 days. White cell count was normal, although I'm not sure about the diff. Her hemoglobin was normal. Her platelets were 144 initially, and she had a CRP of 20. I don't know the reference ranges for this urea creatinine and really what this means, but I think that they're pretty normal. And there's the malaria test, which was negative. 2 days later, her platelets had dropped to 88, again in the CAR, and the following day had dropped to 79. And she then flew out on the 23rd and saw me on the 24th, and her platelets were then 137. She had a neutropenia with a normal lymphocyte count, a normal eosinophil count, and a normal hemoglobin. Her CRP had dropped to 2. Her urea and creatinine were normal. Her bilies were completely normal, but you can see that she had transaminitis with an ALT of 266 and AST of 146, and our malaria test was also negative. So I thought, well, it sounds like dengue is reasonable, or a similar arbovirus, chikungunya perhaps, and she certainly doesn't need antibiotics. So I asked her to stop the cafixime. She was on her 2nd day of it, just to give her symptomatic treatment. So paracetamol, the fever seemed to have gone by then, just Panado for the myalgia and the back pain. She said the pain was slowly starting to improve, but now she just described this extreme fatigue. She just wants to sleep, has no energy for anything. And as you saw, her bloods were really improving by the time she got to South Africa. So we sent blood off to the NICD, and her dengue IgM and IgG were both positive, with a positive dengue PCR. Her chikungunya, interestingly, had a positive IgM and a negative IgG, but the chikungunya PCR was negative. So she certainly has got signs and symptoms and diagnostic evidence for having active dengue infection. Is this a dual infection, and could she have had chikungunya at the same time? She's going to have repeat serology next week to see if that IgG has become positive, and then we'll obviously know whether it was just dengue or just chikungunya. We didn't do West Nile and all the other kind of arboviruses because we felt that these were the most likely and most sounded the best diagnosis. So let's talk a little bit about dengue, and then I'm going to tell you about another patient which I've seen, and I've put it later on because of the way this patient presented, because she was quite interesting in terms of going on into different stages of the dengue clinical presentation. So the first description of dengue goes back to the early 18th century in the Caribbean islands, and that was long even before germ theory. They were still on sort of the breakbone fever type of diagnosis, which was described as dandy fever. And later it was believed that dengue had been introduced into the New World from Africa during the slave trade. But even before the Caribbean, maybe these descriptions of a dengue-like illness could have been dengue. It was recorded in Chinese medical encyclopedias. But the first description of a dengue outbreak was in 1779. And as we'll see, this is becoming one of the most important mosquito-borne viruses or mosquito-borne infections besides malaria, we'll see how this dengue thing has kind of evolved. So again, some other information described by the Queen of Spain, lots of outbreaks around the world, so not just in the Caribbean and in Africa. As we start getting better record keeping and documentation, 2010, we see outbreaks in Croatia and France, Zika virus in Europe for the first time in 2013, and then spread Zika from 2015 to 2019. And so outbreaks of arboviruses in areas of the world where we really weren't expecting to see these kind of viruses. So the dengue virus is a of the Flaviviridae family, genus Flavivirus, and the interesting and frustrating part maybe is that it's got 4 serotypes. It's an envelope virus, and so on the envelopes are these different proteins which will denote it into dengue 1, 2, 3, and 4. It's a single-stranded RNA virus, and because of these 4 serotypes, you can get recurrent dengue infection by different serotypes. So you will have lifelong immunity from the infection or the serotype which causes the infection, but you're still at risk for getting infection by 2 and 3 and 4, for instance. And this becomes really difficult, as we'll see just now, for vaccine development, as well as for the heightened immune stimulation, which happens on recurrent dengue virus infections, and then the risk to getting the severe forms of the dengue virus. So also now becoming one of the world's most important and neglected tropical diseases. And outside of Africa, this is actually becoming the most common and most important mosquito-borne infection. So obviously malaria still tops, but this is the most important worldwide in areas where there's no malaria. And the other things we'd think about, other Flaviviridae, to remind you, are yellow fever, the Japanese encephalitis virus, West Nile virus, and Zika. So it's spread by the Aedes mosquito, which is a pretty mosquito with these white dots and black and white stripes on its legs. So it's really quite easily distinguishable. The problem with Aedes mosquito is that A, it's a female that bites you, but B, it's a day-biting mosquito. So all the malaria prevention in terms of barrier protection, which people are really quite good at, often travelers, and meticulous about, that stuff all happens at night. But the problem with the Aedes mosquito is that it bites during the day. And so transmission of dengue and other Flaviviridae is not going to be protected because we're not putting that barrier stuff on during the daytime. This mosquito is a very domestic mosquito. It breeds in really minute amounts of waters in peri-domestic area. The problem with its eggs is that they are very resistant to desiccation. So it will lay eggs in one season, the whole area will totally dry out, and those eggs remain viable. And one tiny drop of water from the first bit of rain, and the eggs are still viable, hatch, and you set up the whole mosquito cycle again. So these eggs really survive very well without any water for long times. The second thing that's worrying about the Aedes mosquito is the kind of transition from the tropical ancestral home of forests in sub-Saharan Africa, and it's now spread into urban environments in the tropics and the subtropics. And so with globalization and adaptation to geographical expansion, the Aedes mosquito is now a very efficient vector in many countries around the world and many urban environments around the world. So what about dengue transmission? There's 3 types of transmission cycles that are very well described. The first is obviously the forest or enzootic cycle, where the Aedes mosquitoes and the primates in rainforests have a kind of endemic transmission cycle. Then you have rural endemic cycles occurring in small villages or islands where the transmission is contained, and so the virus will disappear after a short period of time because of developing herd immunity. So that is at least something positive. But now, because of globalization, as we said, there's an urban endemic cycle in large urban areas in the tropics. And so you get periodic epidemics of dengue with multiple different serotypes. And this really makes dengue quite difficult to contain and control. Okay, so, sorry, someone's trying to phone me out, so I'm just getting a bit distracted. Why is dengue becoming so important globally, and why are we getting so twitchy about dengue? So it's the fastest growing mosquito-borne viral infection. 70% of the global burden of disease is in Asia, but now it's becoming endemic in just about every single continent around the world. And as we said, in sort of tropical and subtropical climates, it's hyper-endemic. And not just in forests and rural areas, but in urban and semi-urban areas. There's now dengue disease transmission in 36 countries around the world, which were previously dengue-free. So this is really worrying. 36 countries now, and transmission occurring in there's transmission in 129 countries. Of those, 36 were countries which had never had dengue before. So transmission in 129. So this means that currently half the world's population is at risk for contracting dengue, which is a massive number of people. They estimate that there's between 100 and 400 million new infections each year. And prior to COVID, this was the most concerning viral infection globally. So what about in Africa and sub-Saharan Africa? The dengue virus burden for sub-Saharan Africa is a significant cause for public health concern. The IgG positivity in sub-Saharan Africa is around 25%. So 1 in 4 people in sub-Saharan Africa will have positive IgGs for dengue. And 19 countries in Africa have circulation. Unfortunately, still a vast majority of the, well, not vast majority, let's say half of the countries in the continent haven't submitted data or don't have data. So everything that's in gray, we don't have data from. But I think you can see that dengue in Africa is obviously quite a big concern. So the changing epidemiology of dengue, so what this graph is just showing us is how we're getting transmission cycles being set up in countries which have never had dengue, and in areas where there was dengue, massive spikes and peaks of dengue transmission as the years have gone on. Again, number of cases in countries that maybe some of these we do expect, but not others where one doesn't expect to see this, lots and lots. And what I'm just trying to show you over these couple of graphs is how the dengue transmission and dengue virus infection is increasing year on year. Dengue cases in America, also massive peaks. And one can argue that our diagnostic skills have improved, that we think about it more, so we're able to make this diagnosis, that our data collection is better. And those are certainly reasons why 2024 is going to be such a much bigger, higher peak than 1984. But I think the point is just check how this dengue transmission and how this is starting to peak. So what are the kind of things that we're worried about, and why do we think there's increased dengue spread? What are some of the factors? So first of all, globalization and urbanization are the two biggest things. So the explosive population growth with unplanned urbanization, and then overpopulation in areas where public health systems are inadequate is the most important part. We're often talking about areas with poor socioeconomic support, with less funding, less money to do something about this. And because it's not malaria, in areas with less funding, often the money gets put into malaria and malaria treatments and not dengue, because there's no antiviral and one can't really do too much about it. The third part is, as we said, because of the vector, because it's such a competent vector, needs so little water, the Aedes mosquito is such a robust, strong vector, this spreads like wildfire. And again, in these areas, there's not a lot of awareness and education around standing water and water control and keeping water closed and away from homesteads, and so there's massive opportunity for spread. The virus has evolved through the years, and there's also theories that perhaps the dengue virus has in its evolution become more robust, and the transmission from a viral point of view is better as it's moved from sort of primates and the forest into humans. It's changed. We've definitely seen increased travel to endemic areas, which perhaps people weren't doing so much of in the past. Climate and environmental changes have shown a huge impact, changing of weather systems, rainfall patterns, heat, etc. And then obviously ineffective mosquito control, where many of the mosquito control measures against the vector that spreads malaria, which should kill the Aedes as well, but countries with poor socioeconomic circumstances just simply don't have the funds to sort the vector out. So again, dengue has got a very broad differential diagnosis, and it's a frustrating diagnosis because most people will present as an acute flu-like illness with nothing that really stands out to say, hey, think about dengue and test me, unless it's been a traveler coming from an endemic area. So the first thing you'd obviously want to exclude is malaria. You think about all other viral infections, so COVID and influenza if it's the right season. You think about adenovirus. You think about all viruses that cause fever and a rash, like measles and rubella, enteroviruses. In areas where it's appropriate with the right exposure, you think about leptospirosis, rickettsia can present very similarly, typhoid fever, so that's salmonella. And then obviously all the other arbovirus infections, chikungunya, who looks very similar to dengue, West Nile, yellow fever, etc. And then the non-infectious causes, is this a connective tissue disease like lupus or Still's disease? Is it a malignancy? And is it a drug reaction? So when we talk about the symptoms of dengue and the different syndromes, the vast majority of dengue viral infection, thankfully, will still be an asymptomatic infection. And so these people are not going to seek care. But unfortunately, an asymptomatic person is potentially still harboring the virus and contributing to transmission and in reinfection of the Aedes mosquito to continue transmission. So it's good for the human being who's asymptomatic, but not good for public health. And those people who are symptomatic are divided into 4 different types of syndromes. There's an undifferentiated viral fever syndrome. Dengue, so that most people don't seek care. They're not sick enough. They feel a bit fluish, but the symptoms disappear in a couple of days, and there's really nothing in those people to make one think about dengue. The second one is dengue fever. These people may bleed, but usually don't bleed. Then there's dengue hemorrhagic fever, which obviously, as the name suggests, has consistent bleeding. Many times these people have shock, and so that's the dengue shock syndrome. But you can have dengue hemorrhagic fever without shock. And then unusual manifestation and quite rare is the expanded dengue syndrome of isolated organopathy. So sort of localized to one organ without the systemic disease. 75% of people are asymptomatic, which is the good news. The incubation period's between 3 to 7 days. So malaria can go up to 14 days. So this may help in distinguishing a viral versus a malaria. And you really want to have, as a diagnostic criteria, a fever with at least 2 of nausea and vomiting, a rash, aches and pain, so this terrible bone pain that they describe, a positive tourniquet test, or leukopenia. I'll show you what the tourniquet test looks like. And then again, you'd think about it in a patient who's living in or has traveled from an endemic area. So like any viral infection, the symptoms are so non-specific and can be multi-system involvement. The thing I always like to think about when I'm trying to work out is this bacterial, viral, or a malaria thing is to ask about the red eyes. That is quite typical with viral infections to get this conjunctival injection, but it's not a diagnostic thing. It's just sort of a rule of thumb that if you've got red eyes, it's maybe more likely to be viral than not, but the rest you can see are so non-specific. Perhaps the terrible bone pain is a red flag, but again, not everybody gets that. And somebody with flu could have all of these symptoms. The dengue tourniquet test, you blow up the blood pressure cuff over the person's arm to above their systolic blood pressure, leave it for a minute, then deflate it. And what you're looking for are the typical petechiae that happen once you've deflated the cuff. The dengue rash is quite non-specific. It can look like a maculopapular, it can look like a morbilliform rash, it can look like sunburn, just a diffuse red burnt rash. But if you have pathognomonic, these clear islands, so you can see these white areas in between the redness, that is quite typical for dengue. So if you just see a red rash, look for these clear white islands in between. And then it can blanch. So you can see the handprints on this person. If you're trying to work out, is this just some sunburn or is this a viral exanthem? The dengue rash will blanch like that. But you can see how non-specific it is, looking really quite like measles over there. So let's talk now about the different phases in the dengue hemorrhagic fever. So the first stage being the febrile acute flu-like illness for 2 to 7 days, where patients will have a high fever with those list of diagnostic criteria that I described, myalgia, bone pain, etc. Very rarely will these patients bleed. They can have a convulsion due to high fever, but what's starting to happen if they're going to progress onto the second stage, which will happen around day 5 to day 7, is that they start developing plasma leakage syndrome. So they start losing fluid from the intravascular space, and fluid goes into the interstitial spaces, and they start becoming shocked. So their blood pressure starts dropping. And this is the critical period in any patient who's got dengue. Around, if you get to day 7, like the patient we've just discussed, and you haven't developed this critical phase, then hopefully you're out of the woods. But from sort of day 5 to day 9, you really want to monitor the patient very carefully, and I'll tell you how. Thankfully, the critical phase of plasma leakage is short. It lasts for 1 to 2 days, and then it stops. This is a critical time, though, for patients needing to be resuscitated adequately and carefully monitored so that they don't die during this time. If they get past those 48 hours, then one is onto a convalescent stage. And this fits so nicely with how we understand viruses, that you usually start making antibodies around about after a week. And once those viruses really, antibodies really start being produced in larger quantities, you suddenly see a person turn the corner. And that's exactly what happens then after the 48 hours. If they're in the critical stage, or if they're not going in there around day 7, they get antibodies and they start getting so much better. All that intravascular fluid, it gets reabsorbed from the interstitium. So everything that was in the tissues comes back into the blood vessel, their blood pressures go up, and the person really starts feeling much better. Oh, one other thing in this febrile stage, which is consistently reported, is a retroorbital headache. So not just a headache, but a headache behind your eye. If you report that, then think about dengue in these patients. So the dengue hemorrhagic fever, thankfully, of the 25% who get symptomatic dengue, only 1 in 20 is going to develop dengue hemorrhagic fever. So like we said, it's an increased vascular permeability with plasma leaking to the third spaces, and this is where the hemorrhagic tendency is in those 2 days. And this is as a result of an abnormal immune response, a cytokine storm. So that causes the increased microvascular permeability and alters the thromboregulatory mechanisms. And I think after COVID and watching how some people sort of just got a pneumonia or had nothing except flu-like illnesses, and other people went on to this absolute cytokine bonanza with no blood pressure and you couldn't ventilate them, we understand this dengue cytokine storm so much better. The problem with dengue comes in with antibody-dependent immune enhancement, and this is where vaccines or previous dengue infection becomes absolutely crucial in understanding the course of your patient's infection. Because if you've had previous dengue natural infection or dengue vaccination to a single serotype, unfortunately, this causes an immune enhancement to these antibodies and predisposes to an increased risk of dengue hemorrhagic fever in people who already have pre-existing dengue virus antibodies and now get a new infection. So those previously formed immune complexes are not neutralizing for a different serotype of dengue, and they will then attach to the current dengue. They fix complement and the Fc receptors. They facilitate opsonization, and the result of this is the development of a severe viremia and dengue shock syndrome. So every person who's ever had dengue, we really want them to know that they've had dengue so that if they get it again, they can tell us so we can be on high alert looking for this immune complex deposition. So how do you know if the person is going into this critical 48-hour period or developing dengue shock syndrome? Usually they'll start getting better, so their fever starts going down, their pain starts improving, and they actually feel better, and you think, okay, great, they're not going to get worse. But then you get this worsening. The things to look out for are the hematocrit, which starts rising, and that's because the plasma concentration is increasing as the fluid is leaving the intravascular space. The patient's pulse pressure becomes narrow, and then you can do radiology to look for fluid. It might be obvious on your examination, but you look for fluid in the interstitial places or where there's not supposed to be fluid. So you look at the gallbladder for gallbladder wall edema. You look for fluid collections like ascites and pleural effusions, and are all markers that this patient needs to be monitored very carefully and supported through the critical phase. Another thing to look for is dropping albumin levels. And so here I want to tell us about the second patient, which was at a similar time, a couple of weeks before the one that I've already told you. This lady is 21 years old. She'd gone to Grenada, which is in the Caribbean, in the beginning of the year to start medical school. She had no past medical history. She was on some Lexamol, vitamin D, and iron. She'd had grommets removed and adenoids removed previously, but no major surgery, and she was allergic to sulfur. So after enjoying a couple of fabulous months in Grenada, in September, she developed acute flu-like symptoms. She had a headache, she had body aches, she was vomiting. In the beginning, she didn't have a fever, She didn't have a rash as well, and she had lost her appetite. She didn't have any diarrhea. She also described terrible bone pain in her legs and arms, mainly, not as much back pain. And she was told by other students that she probably had dengue. Grenada had recently had a hurricane. It was very wet. It was the rainy season anyway. There were lots of mosquitoes. She said it was just impossible. You just got bitten day and night, no matter what you did to yourself. And the medical students knew that there was an increase in the cases of dengue. She went to the student clinic. The healthcare workers working there agreed and said, yeah, it probably is dengue. Just stay hydrated and take painkillers was their advice. So she went back to her sort of student res and feeling revolting, tried to look after herself. A few days later, she had no improvement in symptoms. She started having nosebleeds. She noticed blood in her urine, and the fever really started pounding. Remember, I said she didn't have a fever initially, so now the fever really came in. She couldn't stop vomiting, starting to get dehydrated. She went back to the clinic, and with concern that she was now sort of at the end of the first week and probably going into a critical phase, maybe the dengue shock syndrome, she was transferred to St. Augustine's Hospital. They did some bloods. Her platelets were low. She had a deranged LFT. She was admitted overnight. She was bleeding more. So she was sent to ICU. Fever ongoing. She was having rigors. She needed a platelet transfusion because of the bleeding. She was managed there for 2 days and then sent back to the ward. They did notice a right pleural effusion. They noticed that she had ascites, and she started on Lasix. So after what we've just said about meticulous fluid management and trying to maintain an intravascular volume, you can see that Lasix was probably not the best idea on her. After being transferred to the ward, she slowly started improving, and after about 10 days was feeling more alive and flew back home to her parents to be looked after by her parents in South Africa. And although she's feeling better, bone pain disappearing, fever gone, myalgia and headache gone, vomiting gone, what she really described for the next month was just feeling really, really weak and absolutely exhausted, this terrible, intense fatigue. So here I want to show you the sonar that they did on her in Grenada, and you can see this fluid extravasation into the gallbladder, where they could see that it was significantly thickened, a multi-layered appearance, extensive pockets of edema. The spleen was a little bit enlarged. She had some fluid in Morrison's pouch. She had a right pleural effusion. She had a tiny, well, they're both pretty small. So it's quite impressive to be able to measure 12 mils and 8 mils of pleural effusion. And then again, also ascites in her abdomen. So she really was in that critical phase of fluid depletion and fluid extravasation. Just to show you her blood cells, so white cell count was low, but she had a normal neutrophil and lymphocyte counts, interestingly. Her eosinophils were normal. Her monocytes were a little bit raised. Her hematocrit was 39%. I'm not 100% sure when these bloods were in relation to her symptoms. So whether this was in the critical phase or prior to that. Her platelets were 59. Her urea and creatinine, those are normal ranges. Those aren't the kind of values we used to looking at, but they're normal. And again, she had this transaminitis predominantly, but also mildly elevated ALP and gamma GT. So she was really quite sick. So just a sort of schematic representation of what I've just told you, looking for different things in different phases of infection. When do the platelets drop? Sort of around day 5, 6, you expect the platelets to be low, reaching their nadir just before the critical phase if it starts, and then slowly going up. The hematocrit rising in the critical phase as the person becomes intravascularly volume depleted. The temperature, look how it settles before the critical phase, and you think, fabulous, this person's doing well, but then actually goes back up again. And then we'll talk about the diagnostic bits with serology, but basically it's the same principle as with any viral infection. IgMs become positive round about day 7. And then you can have IgMs persisting for quite a long time, like 3 months, and then IgG is starting to become positive. PCR, looking for the actual viral protein itself. So you're only going to get a positive PCR in the first few days of the infection. So at least within the first week. And after that, the PCR will become negative and difficult to interpret. The complications of the dengue are neurological. Like with any viral infection, they can trigger Guillain-Barré syndrome and encephalopathy and neuropathy. They can affect the gastrointestinal tract, causing a hepatitis, a pancreatitis, a cholecystitis. You can get a nephritis, a myocarditis, a pericarditis, a myositis, and obviously the low platelets hematologically. So the dengue diagnosis, as I've alluded to, we look for the actual virus isolation with PCR. You can look for genome detection. You can look for antigen protein detection. So those are all direct methods and are very specific, versus looking for the antibodies to the virus, which is far more easily accessible and much cheaper, but very frustrating to interpret because of when things become positive, because of cross-reactivity between different arbovirus antibodies, and also because of false positives. So, like we said, you really want to do a PCR in the first 5 days to look directly for the viral genome and a definite diagnosis. After that, one is kind of reliant on serology, IgM, IgG, and a seroconversion between the two. So this is just trying to show you what we've discussed a couple of times already, and when things become positive and when things become negative, and it's really in the same principles as any viral infection. How do you manage these people? So in the febrile stage, it's symptomatic. So make sure they're well fluid resuscitated, give paracetamol for fever and pain, and really try and avoid the non-steroidals, because many of these patients get dehydrated and aren't eating. So all the complications of non-steroidals in terms of renal dysfunction and ulcers, gastritis, etc., become a problem. In the critical stage, one doesn't want to fluid deplete these people, and they actually require really good fluid resuscitation and not the administration of Lasix, although you think, well, they're so puffy and they're fluid overloaded, so we've got to get rid of the fluid. What you're trying to do is get the fluid back into the intravascular compartment, and there's equations to work out how much fluid an individual person needs and how to administer it. So on average, for 50 kilogram person in that critical stage, they need 4.5 liters of fluid in 2 days. So I know it feels counterintuitive, but they actually need the fluid and not the Lasix. Unfortunately, antivirals show no efficacy. If necessary, you're going to top up with blood products like platelets or whole blood if the hemoglobin's low. Steroids may have a benefit in dengue myocarditis, but not as a rule in patients with dengue. It doesn't really make any difference. Unfortunately, there's insufficient knowledge with immunoglobulin therapy in dengue patients. Very little known. One of the studies I read showed 5 patients who were treated with dengue antibody negative gamma globulins, and their platelets rapidly increased. So they were just given pooled globulins, is what I'm saying. So not necessarily dengue antibodies, just sort of polygam type stuff. And their platelets increased quickly, but they didn't tell you whether these patients actually survived or died, even though they had good platelets. Antihistamines have been trialed, so rapatidine shortened the symptoms and reduced the disease severity. Don't ask me how antihistamines work, unless maybe on the basis of trying to flatten or limit that cytokine storm that gets with a dengue hemorrhagic shock syndrome. And then you might want to give Parvolex in patients who've got liver involvement and go into liver failure. There have been multiple dengue antiviral drug development attempts. None of these are showing any promising signs, and up until now, there's no antiviral for dengue. Again, these are some of the things which have been trialed, and you'll recognize some of them from COVID days, like ivermectin and vitamins and other interesting things like the mast cell inhibitors and metformin. None of these really make much difference, and so we're basically on symptomatic management with Panado, rehydration, and then managing this fluid status. So in terms of prevention, this is maybe the most important part, since there's not much we can do with a patient who's got actual dengue. So what are the things that are important from a vector control and a vaccine development point of view, which are the two ways to try and prevent dengue? So unfortunately, the vector control strategies have been less effective than the malaria vector control strategies, because this Aedes mosquito is so highly domesticated. They're trying to use genetically modified male mosquitoes to sterilize the wild type female populations. They use embryonic introduction of strains of the Wolbachia bacterium into the Aedes, which makes the mosquito resistant to the dengue virus. Mozzie nets obviously is a problem because you're only under that at nighttime, so in the daytime. So maybe vector control, the thing that we can do is to still use mosquito repellent during the day and not just at night, and tell our patients that when they're going into a dengue area. Dengue vaccine development is very challenging, and there's lots of reasons, and we don't have too much time, and it's so complicated that I don't understand all of it, so I'll never be able to explain it at all. But the issue basically is that the vaccine has to cover all 4 serotypes of the dengue virus because of this immune augmentation, where if you are only immune to one serotype and you get a subsequent dengue infection, you get immune augmentation and a cytokine storm. So you really need a tetravalent vaccine for all 4 serotypes for it to be effective. And all of this has really been a big stumbling block in the development of an effective dengue vaccine. So the first licensed vaccine is Dengvaxia, which was authorized and licensed in 2015 and is currently the only FDA licensed vaccine, but this is going to change pretty soon and might have even changed now in the last 2-3 days. Its efficacy is between 50 and 70%, depending on the dengue serotype that you are infected with. So although it contains all 4 of the serotypes, the efficacy to serotype 1 is less, for instance, than to 2, for instance. And there's also decreased efficacy if your patient has never had dengue before. In other words, if they're seronegative at the time of vaccination. So this vaccine is actually more effective in people who've already had dengue. And so because of that, you need to give the vaccine only if there's lab confirmed evidence of previous dengue. So you actually have to measure this antibody levels, so do serology in these patients before they become eligible for this vaccine. So it's recommended in children between the ages of 9 and 16 who live in endemic high-risk areas, who have evidence of dengue positivity. And unfortunately, there's no evidence for efficacy in people over the age of 16. So this is not an effective vaccine in adults. You don't want to vaccinate somebody partially to dengue because you increase their risk of a more severe disease outcome. And the aim of all vaccine is to be effective against all 4 dengue serotypes so that you elicit, hopefully, equal levels of neutralizing antibodies to all 4 serotypes. Okay, this is what, sorry, I don't know why this says the exact same thing again. Okay, so because you need to prove the positive serology in the patient, you can see that in the vast majority of the world, there's no role for this. We're not able to measure dengue serology in countries with poor socioeconomic circumstances. And so this Dengvaxia vaccine was hardly ever used. A second vaccine was Qdenga. Unfortunately, the FDA approval was withdrawn in July 2023, so it's not available in the USA, but it is approved and available in Europe and the UK and Southeast Asia and South America. The good part about this vaccine is that it can be given to people who've never had dengue before. It's a 2-dose vaccine spaced apart by 3 months. The efficacy is 84%. At 4.5 years, 84% of people have mild infection and do not require hospitalization. And against symptomatic dengue, 61% at 4.5 years have not had symptomatic dengue. The problem with it is that depending on which serotype, again, the efficacy is not the same. So its best efficacy is against dengue 2. Dengue 3 and 4 efficacy is unclear, and that's not necessarily a vaccine issue, but because we have such low circulating levels of dengue 3 and 4, they haven't been able to try it against these serotypes. Most people with dengue have dengue 1 or dengue 2. So it might be fabulous against 3 and 4, but we just haven't seen enough 3 and 4. It's also indicated in 9 to 16-year-olds. So you would try and give it a year or two before the age-specific peak incidence in an endemic area of dengue-associated hospitalization. And we were expecting a traveler recommendation this year for specific situations in which this vaccine would be recommended. There are some vaccines in study still, TB005 and TB003. These are single-dose live attenuated tetravalent vaccines. They're currently in phase 3 in this multi-center study in Brazil. The nice part is that it seems to provide a balanced sero response to all 4 serotypes. So far at 3 years of follow-up in Bangladesh, 80% overall efficacy at 2 years, 90% against dengue 1, 70% efficacy against dengue 2, and again, no data on dengue 3 and 4 because they just haven't had 3 and 4 circulating in the patients. But again, just to point out, in people who've never had dengue, the efficacy of the vaccine is lower. So these vaccines are better in people who've already had dengue. So just a quick slide on malaria to remind you that malaria is still our biggest priority in Africa, but to show you how dengue is fast approaching levels of concern even for us, with 50% of the global population of both being at risk, malaria being a parasite, dengue being a virus, dengue being a day-biting mosquito, malaria a night-biting mosquito. Dengue, thankfully, 75% have an asymptomatic infection versus malaria where most people are symptomatic initially. Obviously, if you live in an endemic area, it's different. Dengue has far wider global transmission, whereas malaria, the main burden is in Africa, and 94% of the mortality is in Africa. Dengue, there's transmission in urban areas. Malaria is mainly in rural areas. Thankfully, the dengue has a far lower mortality rate than malaria. Both of them have similar incubation periods. Maybe malaria would stretch to 14 days. The symptoms of both are really similar. Malaria is effective medication, and as we've said, dengue, there's no antiviral. So to end off quickly, 3 more minutes, just to have a look at dengue in South Africa. Although we have Aedes aegypti mosquito present in Natal, in Limpopo, in Mpumalanga, in Gauteng, we currently haven't detected dengue in South Africa. So we've got the Aedes aegypti. We don't have Aedes albopictus. But we also do have a suitable environment. Our climate is good for this mosquito, and the vector and population are certainly very vulnerable for infection with dengue virus. We don't know how competent our vector is. There have been 3 descriptions of, I can't even say that word, contiguous transmission in South Africa, which has all been from importation through infected human travelers. In 1901, in 1926 and 1927, 50,000 cases described with 60 deaths. And then from 2000 to 2016, the NICD reports 176 cases. Countries of origin, these are travelers returning from the kind of places we would expect. The rest of Africa, Southeast Asia, America, and India. Sorry, I heard noise there. Just must I stop?
No.
Okay. So I'm nearly done, I promise. I'm sorry, this is going on forever. It's just so interesting. So there's so much to say. So what can we do about it in South Africa? So we obviously need to have vector surveillance programs, and there is a vector surveillance program in KZN. We need to improve the country's recognition and response to arbovirus outbreaks, and people need to understand and know and think about dengue. And I think in South Africa, we usually don't think about dengue because it's not something that is an issue here. It's important to test local populations for seropositivity. So there's studies now and again where they go into the population and check IgG levels for dengue to see, are they getting asymptomatic infection? Are we missing it? And obviously in returning travelers, that's the most important, because a returning traveler coming back to South Africa who's viremic could infect our Aedes mosquito and set up a little local transmission. So there is a research program, like I said, in KZN to look at the prevalence and to try and stratify future risk. The areas to highlight with this are thankfully at the moment, we don't have competent mosquito vectors at major air entry areas in South Africa. So Cape Town and Joburg. Ground migration is more significant though. We don't have the majority of our people entering the country by plane, but rather by road transport from north of us and east of us. So that is a problem. KZN, the vector is competent. It's in a tropical area. And so this is a potential introduction of viremic people and setting up infected mosquitoes into arbovirus permissive areas. Sorry. So what I meant to say is Cape Town and Joburg are maybe still too cold and not great areas for the vector. The problem with dengue is that because 75% of people are asymptomatic or just have a mild flu-like illness, they're unlikely to seek medical care. And so we are unlikely to notice a dengue outbreak until an endemic cycle has been established and the arbovirus has been introduced locally. The testing is difficult because there's very limited access to testing. It's expensive. The NICD needs to do it. And it's just not accessible to people who are living in the rural areas. So early recognition and diagnosis are key, but are very difficult. And so I'm going to end off over here with an email that Albie shared with me, which I didn't really understand, just trying to talk about the vaccine and the efficacy and how amazing the yellow fever vaccine has been in preventing disease transmission. And so should we be focusing our efforts on the dengue vaccine to prevent travelers returning and setting up local transmission? And is this a way to kill and not set up local transmission? It's really quite a complicated topic, and I'm not sure I really understand all of his points, but Albie, maybe you can tell us if you've spoken to this man, to kind of give us a quick summary of what he basically said over here.
Hi, right. Can you hear me?
Yeah.
Yep. Yeah. So the question really was, if Aedes is the vector for yellow fever, and also for all these other nasties, dengue and chikungunya and Zika, and we've got a vaccine for dengue. We're using yellow fever vaccination to try and curb the spread of yellow fever. Why wouldn't we use the vaccine to curb the spread of dengue? Because we've seen the massive strides dengue made from Southeast Asia to South America, basically in the last summer season. And aren't we going to be next with global warming, et cetera, et cetera? Because we do see the odd case, like we've seen in this lady from Central African Republic. We know we've seen cases from northern Mozambique, for example. I've seen positive rapid tests in laboratories in Angola a few years ago already, and it's like, oh yeah, we see dengue. So why wouldn't we use vaccination to stop that? And we'll have to go back to the vaccine a bit. And this was from Ralph Witz, who is part of CDC, and those are his answers. And so I'm not going to go through it in detail, but because we didn't talk that much about chikungunya, maybe you need to come back and talk about chikungunya, and we've got to decide still whether our patient actually had a double infection, whether it was dengue and chikungunya.
Yeah.
So the bottom line, so we don't have a vaccine for chikungunya, so let's forget about that one for now. Sorry, there is one. There's a brand new one, but that's not gone out very far yet. I think it's called Chikrix. But for dengue, we do have the vaccine, and thank you very much for the lots of trouble you went to in setting up the talk. But when I attended the Northern European Conference on Travel Medicine in Copenhagen in May, I was gobsmacked because it was just Qdenga was all over the place, and Takeda, that makes it, was promoting it. And I had a brief look at the UK and some of the European guidelines on using this vaccine. And I also met with a group of Brazilian tour operators that were visiting South Africa with a view to bringing a group of 160 people here next year. And they all sort of in their 30s, 40s, thereabouts. And I asked them about, did you have a problem with dengue back in Brazil this year? Oh, yes, but we also all have been vaccinated. So I've also got in my head that the dengue vaccine is under special circumstances proof that you've had dengue before certain age groups. But the impression I got both in Copenhagen and from the small bunch of Brazilians is that everybody's dishing out Qdenga vaccine like it's going out of fashion.
Yeah.
Which is why I was wondering, well, should we start fighting to have it in Africa? And why would we not use that then also to try and curb the spread? Because we're not successful with all our own diepsloot and kailichas around our urban areas that are full of litter, full of standing water that these mosquitoes just love. I don't think we're going to win on a vector control side. But these were the answers from Ralph, and the bottom line of it is it's probably not suitable to the last one is probably the bottom line. Long-term efficacy data for dengue vaccination are not yet available.
Yeah.
But so thank you very much.
So thanks, everybody. If there's any questions, we can chat about that quickly, I guess.
Okay, but are we going to get that second round of bloods from Ms. Marav?
Yeah, she's very on board to do it next week. So that'll be nice. We hardly ever get a second round of blood, so that's fabulous.
And then we can submit it to Geosentinel as a double infection from Central African Republic.
Yeah.
But she seems to be a little bit of a magnet if she picked up some other tick-borne disease in Europe, and now she's picking up dengue and chikungunya all at the same time.
I know.
She clearly doesn't go for the normal malaria thing.
I think the chikungunya is previous exposure. I don't think it's going to or cross-reacting antibody. I guess it can't be previous exposure. IgG is not positive, but let's see.
And then just for what it's worth, with ISTM, we recorded a podcast. That's where Ralph Witz was one of the speakers. We recorded a podcast on chikungunya and dengue a week ago. So that's supposed to be launched in the next week or two.
Oh, nice.
Good. Thank you very much. Thank you very much, Kim. Lots of work. Thank you very, very much.
Pleasure.
I don't know if there's any questions around the table. I don't see any on the chat. So if there's any around here, I think we're going to close the meeting. But thank you so much, Kim, for all the effort for the slides and everything. It was amazing.
Pleasure. Thanks, everyone, for listening.
Great.
Ready.
Thank
Cheers.
you.
Bye.
Bye.
John, I can just see you dying to say something, but I thought let's